My name is Bo Abrahamsen. I'm a consultant endocrinologist at Holbæk Hospital and a clinical professor of database studies at the University of Southern Denmark. I would like to present on behalf of my co-authors the results of a nationwide observational study on the long-term skeletal risks and benefits of alendronate treatment for osteoporosis. I would like to begin by acknowledging my co-authors in Copenhagen, Oxford and Sheffield. In recent years, the treatment gap for osteoporosis has been widening in Europe and in the United States due to concerns that antiresorptive treatment could lead to atypical femur fractures, which could offset the benefits of long-term use. Atypical femur fractures form a distinct radiological subtype of femoral subtrochanteric and shaft fractures. The aim of the study was to determine the risk of subtrochanteric and shaft fractures as a function of cumulative alendronate use, time and adherence. It's a subset of femur fractures that captures the total rate of atypical and typical femur fractures, which can then be compared with the number of hip fractures prevented. We performed an observational study using Danish health registers. We did nested case control analysis in an alendronate user-only cohort with a treatment start 1996 to 2007, followed for outcomes to the end of 2013. This illustrates the change in fracture rates as a function of treatment duration on alendronate for hip fractures in blue and for subtrochanteric and shaft fractures in black. After an initial decline in fractures for the first 5 to 10 years of treatment, we may see a beginning of an increase in fracture risk for both types of fractures, though this may be caused by longer treatment in high-risk subjects. And there's also a much broader confidence interval paralleling the smaller number of patients still adhering to treatment. Certainly for up to 10 years, the number of hip fractures estimated to be saved, shown here as a red line, is comfortably higher than the total number of subtrochanteric and shaft fractures. So even if we were to assume that all subtrochanteric and shaft fractures were atypical femur fractures, which is certainly not the case, there would still be an overall benefit of alendronate treatment for up to 10 years in terms of absolute fracture numbers. This slide shows the nested case control studies in red for subtrochanteric femoral shaft fracture and in green for hip fracture. For the subtrochanteric and shaft fractures, it's evident that there was no increased risk of these fractures in current users compared with past users, in patients adhering with more than 80% compared with those adhering with less than 50% of doses, and in patients treated for more than 10 years compared with less than 5 years. By contrast, for the hip fracture outcome, there was clearly a lower risk of hip fractures in current users, there was a lower risk of hip fractures in those highly adherent to treatment, and there was a lower risk of hip fractures in those treated for more than 10 years. This was almost exclusively a North European population, so findings may not apply to populations in areas of the world with a higher risk of atypical femur fractures. X-ray images were not available, so the absolute harm rates reported here are inflated by inclusion of non-atypical subtrochanteric fractures and shaft fractures. It's already known that placebo-controlled clinical trials have found a reduction in hip fracture risk with alendronate compared with placebo for 3 years in postmenopausal women with osteoporosis. Moreover, observational studies have suggested that atypical femur fractures involving the subtrochanteric femur or the femoral shaft are more common in long-term users of bisphosphonates. Long-term adherent use of alendronate in excess of 10 years was associated with an adjusted 30% lower hip fracture risk and no increase in the risk of fractures of the subtrochanteric femur and femoral shaft. Even if all subtrochanteric and femoral shaft fractures observed in alendronate users were atypical, the number remains too low to offset hip fracture benefits in long-term alendronate treatment for up to 10 years. Our data support a good benefit risk of alendronate therapy in terms of bone health for over 10 years of continuous use. Long-term exposure data linked to radiologically adjudicated fracture outcomes are recommended to accurately determine the true and possibly even lower rate of atypical femur fractures.